if you only
Are there
receive
any
one
other?
dose.
Are there any other questions? Oh, I see that Dr. Siegel has his hand up.
Hi, great case. The tocilizumab, can someone explain how that helps? Or what is that targeted to do?
So tocilizumab can be given when there's an overflow of immune markers, where basically there's an overexposure of IL-2 everywhere in the body. She basically had an uncontrolled immune stimulation, and so non-specifically it suppresses all lymphocytes and immune markers to kind of decrease that reaction and suppress the macrophage overgrowth. There's actually no good mechanism that has been identified of exactly how it works, but it can be given in severe cytokine release storm reactions when people get IL-2 and CAR T therapy, and in this case as well.
Thank you.
Any other questions? Okay, well, we'll just take a minute or two for a break. And Adam, excellent job. Thank you very much. All right, well, let's get started with Grand Rounds. So in just a minute, I'm going to ask Dr. Phillips to introduce our Grand Round speaker. But in the meantime, just a brief announcement about attendance. We'll be taking attendance at 8:10 using the participants list in the WebEx. If your name is displayed clearly, then you'll get full credit for attendance. If your name is not displayed clearly, or if there's two people sitting at the same computer, you can email your attendance to me or Beth or Michelle. And with that, Dr. Phillips, are you ready to introduce our speaker?
I am. I am very happy to introduce Dr. Julia Keltz, who looks like she is a true New Yorker. She went to undergraduate at Rochester Medical School, Albert Einstein in the Bronx, residency at NYU, fellowship in minimally invasive gynecologic surgery back at Albert Einstein, and is now a assistant clinical professor and residency program director at NYU Medical College, as well as Westchester Medical Center. Dr. Keltz has research in endometriosis, pelvic pain, as well as issues of disparity. She's very well published in these areas in the Journal of GYN Surgery, the MIGS Journal, and somewhere in her background, I see there might have been an interest in infertility, as there is a little bit of smattering of infertility research and publications in her background. She has a CV full of teaching and MIGS awards. And I think with this background, she is very well prepared to teach us something today about chronic pelvic pain, making the care a lot less painful. And so, Dr. Keltz, thank you for being here today, and we look forward to hearing your presentation.
Thank you so much for having me today, and thanks for that lovely introduction. I'm Julia Keltz, and I am excited to share with you all my passion for chronic pelvic pain. I'm like one of the strange people that love this. It's a fairly long talk, so there's some parts of it that I'll go through kind of quickly, but I'm really excited to share with you all today. So thanks for having me. So first, I have no disclosures, but I love this slide. This is a photo of Bryce Canyon National Park. And I like to include this at the start of this talk because chronic pain patients are very complicated and their landscapes are different and changing and multifaceted. And as a physician, we need to take the time to step back and see the full picture for this patient and what the whole person needs and what all the things we need to consider instead of just looking at the one specific thing they're coming to us for. So if there's one thing that you gain from this talk today, it's that this disease is so complicated and you really need to think about the whole picture of the patient, not just the one GYN component that we tend to focus on. The objectives of the talk today are to identify patients with chronic pelvic pain and consider a differential diagnosis, initiate a diagnostic evaluation for patients with chronic pelvic pain, and recommend an initial treatment plan for patients to help facilitate appropriate consultation for care. And I try to have this be somewhat interactive, so there's some cartoons, and I do have some Slido survey slides. So for those of you who have a cell phone available, I encourage you to participate with your cell phone as well. So our outline for today, we're going to discuss what is chronic pelvic pain, and then we're going to go into some of the specifics of the different components of the disease. So central sensitization, endometriosis, adenomyosis, interstitial cystitis, irritable bowel syndrome, myofascial pain, psychiatric illness, and we'll summarize. This is not a comprehensive list. This is just what we're going to get to today. But there is so much more to this, and each of these topics on their own could be a grand rounds. So please take out your phones. We're going to start with this Slido. So you can either join us at slido.com or you can use the QR code, but just share with us. This is anonymous. So if you could share with us, what are your thoughts when you have a patient who comes to you with pelvic pain? I'm sure most of you aren't like me going, oh, this is so interesting. Let's see what they have going on. Participants. Helpless. You know, some people feel scared to have a pelvic pain patient, or it's going to be annoying or frustrating. See if we get a couple more before we Go to the next. Extensive workup. I love it. It's definitely an extensive workup. Sympathy, yes, they're complicated. They're incredibly complex. And all of us have these constraints. We're booked 4 patients an hour. And how can you sit down and have a whole long amount of time to get through all the information that these patients require? And really, these patients truly require dedicated time and listening. Having an ear to listen to these patients is so important. So yeah, all of these things are definitely true. And being able to kind of sift through all of the symptoms that they're having and the complications that it's impacting on their life really can be very difficult. So what is chronic pelvic pain? By definition, it's pain of 6 months duration or more that occurs below the umbilicus and is severe enough to cause functional disability or require treatment. It's often associated with negative cognitive, behavioral, sexual, and emotional consequences, and it may be cyclic or non-cyclic or related to menstruation. And this is something that I think people get hung up about, because sometimes the thought is if it's cyclic, it's not chronic pelvic pain, but technically 6 months duration of pelvic pain is considered definition chronic pelvic pain. About 25% of females have chronic pelvic pain, and it accounts for up to 10% of all GYN visits. It's 40% of gynecologic laparoscopies in the United States and 12% of benign hysterectomies. The cost is over $5 billion per year in the United States, and that number is going up yearly. But interestingly enough, 80% of chronic pelvic pain is not GYN in origin, and so we really need to be considering what that means. Their common symptoms: pelvic or vulvovaginal pain or pressure and dyspareunia, urinary frequency, urgency, retention, dysuria. They can have abdominal and pelvic pain, pressure, bloating, nausea, constipation, diarrhea, pain with change in bowel movement or frequency, pain that is sharp, cramping, cyclic, or continuous in nature. They may have heavy or irregular menstrual bleeding, burning pain along dermatomes, and you can have central sensitization syndrome. And I like to think about it as that the pelvis is this kind of area where there's the pelvic floor dance, right? So you have the bowel, you have the uterus, you have the ovaries, you have the fallopian tubes, you have the bladder, you have the bones, the muscles, the joints, the ligaments. There's so much going on there, not to mention the nerves, the psychological impact. Everything that goes on in the pelvis plays a role on each other. And so when we think of a differential for pelvic pain, there's central sensitization, which we'll discuss. There are GYN causes, there's non-GYN causes, but many of the time this comes together, and there's grade 2 evidence that multiple pelvic pain syndromes often coexist. 48% of patients with interstitial cystitis have endometriosis. So there's some literature that quotes that up to 60%. 30 to 75% of patients with IC have irritable bowel syndrome. 38.5% of patients with chronic pelvic pain have irritable bowel syndrome, and 24% of chronic pelvic pain patients have bladder symptoms. And this was found from a large systematic review on chronic pelvic pain published in 2021. So this is pretty recent data. So we're going to first talk about central sensitization. And when we think about this, there's all these visceral structures in the pelvis, so uterus, bladder, bowel, and then you have somatic structures, the skin, the fascia, the muscles, the bone, and all of them share neural pathways. And it can be difficult to differentiate between somatic and visceral causes of pain. And like we talked about, there's difficulty in localizing that pain. So what is central sensitization? And it's when you have this viscerosomatic conversion. So we talked about what the visceral and the somatic structures are, and they receive signals from an input to the CNS through the spinal cord. And I say the spinal cord is the gatekeeper of all the sensory that we have from coming outside. And you normally have some viscero cross sensitization. So that's when one organ hypersensitizes another organ. So the most common example in the pelvis that comes to mind for me is when patients say when they get period poop, or that they have changes in their bowel function when they have menstruation. And sometimes this isn't that it's a negative thing. They might just notice, I have more frequent bowel movements during menstruation. And this is viscero to viscero cross sensitization. However, when you have chronic pain in one of those areas, you can get viscerosomatic convergence. So that's when you have persistent visceral nociceptive stimuli that can lead to noxious somatic stimuli. So that is how something like irritable bowel syndrome, interstitial cystitis, endometriosis can lead to pelvic pain and pelvic floor hypertonicity, myalgia, low back pain or dysfunction. And conversely, persistent input for malfunctioning pelvic muscle injury or surgery can also lead to visceral dysfunction. So you can have someone with pelvic floor spasticity may have urinary urgency or frequency, or they may have persistent bowel symptoms or constipation. And all of those things play into each other. And so the way I explain it to my patients is that when you have constant stimuli, visceral stimuli, negative from whichever organ to the spinal cord, eventually the spinal cord has difficulty determining the difference between painful stimuli and non-painful stimuli, and everything gets received as painful. And this enhances the CNS responsiveness. You have decreased pain inhibition, you have pain hypersensitivity, and this leads to widespread pain. It can cause sleep disturbance, and it can have significant psychiatric impact. And you really need to pay attention to these symptoms, because if you do not treat all of this, you're not going to feel better. So treatment for central sensitization needs to be multimodal. 50 to 90% of patients have chronic pelvic pain that originated from musculoskeletal structures. So you need to examine the musculature, and I will go through that later in my talk. If you only focus on visceral or organic pain courses, you're going to neglect the central sensitization and myofascial dysfunction, and it may lead to prolonged pain and delayed treatment. So you do need to treat the origin of the pain, so endometriosis, let's say, but you also need to treat the sensitization, or they're never going to feel better. So you need to think about what are those nerve pain symptoms. You need to think about the myofascial dysfunction and the muscle spasms. And then you also need to think about the psychiatric components of this, because if they have anxiety that they're going to be in pain, if they previously, when they would go to a wedding, would keel over in severe pain, and now you're treating them, but they have this anxiety that they're going to keel over in pain in the wedding, that will lead to muscle tension, which can then trigger an actual pain episode. So you really need to think about all of this. And for these patients, surgery may worsen symptoms, because by filling the belly with air and doing surgery, you're actually stimulating all of those receptors inside the pelvis and the peritoneum, and that actually heightens their pain postoperatively. For these patients, you want to think about, non-pharmacologic treatments such as physical therapy, exercise, cognitive behavioral therapy, meditation, and mindfulness practices. And then you could do some neuromodulation like TENS, PTNS, sacral neuromodulation tends to work well, and pudendal neuromodulation. Other medical neuromodulators we treat with anticonvulsants such as gabapentin or pregabalin. You can use tricyclic antidepressants. Amitriptyline tends to be the most common, but you can use nortriptyline as well. And then the third line would be SSRI, and you can use things like Paxil, Zoloft, or Prozac. And then surgical intervention may be required, but you have to recognize that they may need some additional therapy to help reduce the central sensitization. Okay, endometriosis. This is a very large topic, so we're going to go through it somewhat quickly, but this is a really important diagnosis to be looking out for. So endometriosis is a systematic chronic disease with heterogeneous presentations. It affects 5 to 10% of reproductive age women, and the average age of diagnosis is 28 years old. Typically, diagnosis takes 4 to 11 years, and the difficulty with diagnosis is that women have difficulty articulating their symptoms, and they are inappropriately normalized. And the current requirement for surgical diagnosis can be a barrier for early recognition and treatment. And lesions can be missed on surgery as well, and it can be thought of as a variant of normal. So you really want to have it heightened in your awareness. And I do generally say to my patients, we don't have to do surgery initially to say that this is likely endometriosis and begin treatment. The amount of disease does not correlate with symptom severity, and peritoneal implants don't localize to symptoms. Presentation, about 20 to 50% of patients present with subfertility, so you may not have pain, and about 70 to 90% of patients present with chronic pelvic pain. And patients with endometriosis, 50 to 80% of them have pelvic pain. And up to 50% of patients with infertility have endometriosis. So for a patient that comes in with primary infertility and you can't figure out why, and their FSH is normal and they seem to have normal ovarian function, their fallopian tubes may be normal, you want to think endometriosis, because even doing a laparoscopy on them can increase their fecundity. So like we talked about, early diagnosis and initiation of therapy early in the earlier stage of disease is crucial. This reduces the long-term sequelae. They tend to have fewer fertility issues if you intervene early, and then you can help reduce the progression of the disease. Some of the risk factors include early menarche, short menstrual length, heavy menstrual periods, nulliparity, and a family history is a 7 to 10 times increase if it's a first-degree relative. And there are three main phenotypes. 80% of patients will have superficial peritoneal implants. It's the most common thing we see on laparoscopy. Ovarian endometriomas, when endometriosis kind of takes over generally a follicle or some sort of ovarian cyst, or deep infiltrating endometriosis, which is when it extends 5 millimeters or more below the peritoneum, or infiltration into the muscularis propria of a hollow viscera, so bowel or ureter or bladder. The pathophysiology is still being kind of investigated, but all four of these seem to have some evidence in the literature that we have examples of. So it may be variable per person of how they got their endometriosis, but retrograde menstruation, where the bleeding, the period goes outside of the fallopian tubes and implants inside the pelvis, hematologous and lymphatic transport, stem cells from bone marrow, and coelomic metaplasia. But regardless of how those implants got there, they all are doing similar things. So the thought is that you have these ectopic endometrial tissue that overexpresses estrogen receptor beta. And this estrogen receptor beta overexpression promotes cell survival and perpetuates the inflammation. So you get this increased estradiol locally at the endometriosis lesions. That leads to overproduction of the endometriosis. It leads to local overproduction of prostaglandins. You get increased aromatase activity, so then you continue to ramp up that estrogen response, and then ultimately you get progesterone resistance. So again, you have this, when you have estrogen and progesterone in the body, the endometriosis lesions are really only seeing the estrogen and they're continuing to grow. And this leads to this chronic inflammatory disorder with increased cytokines, macrophages. You get growth factor, TNF alpha, IL-1, 6, and 8. And I have a schematic here. But this leads to like angiogenesis, growth of nerve fibers to invade the lesions. You can get fibrosis and scarring, and you really get this recruitment of all these inflammatory cells, which lead to chronic inflammation. So diagnosis, like we talked about, it's really important to get a comprehensive history and physical exam. You can do imaging, and you want to look for other causes of pain. Ultrasound can show an endometrioma. You would see generally a unilocular cyst, but it can be complex with multi-septations occasionally. You may have one or two endometriomas in an ovary, and you see these low-level echoes throughout because that's thickening the blood of the endometrioma. You may have deep infiltrating endometriosis, as you can see in ultrasound. It depends on your ultrasound tech, but if they're comfortable in looking for a sliding sign, it's when they move the uterus to see that it's separate from the surrounding visceral structures. And then MRI, generally if you're taking someone to the OR, I generally, for patients who have an endometrioma on ultrasound, I send them for MRI to see if there is more extensive disease, because I need to call in my colleagues to help when there's more invasive bowel disease or bladder or ureteral compromise. Surgery remains the gold standard for endometriosis diagnosis, and you need to have histologic findings. Although 40% of patients who undergo laparoscopy for endometriosis are found to have nothing on laparoscopy, and 80% of those who go to the OR and found to have endometriosis have peritoneal disease. So this is all superficial peritoneal disease, but the lesions can vary significantly in the OR, so you really have to look. You can see the image on the left shows sort of those classic endometriosis lesions. And then the image on the right, they're more vesicular lesions. You really need to go up close with the laparoscope and take a look. The most common areas would be kind of the dependent areas in the pelvis, so the posterior cul-de-sac, the uterosacral ligaments, and you always want to look underneath those ovaries in the paraovarian fossa. I have been surprised before with just wispy fibrosis of the peritoneum that you can see through really nicely, and I've taken out peritoneal, done peritoneal biopsies, and they've come back with endometriosis. I didn't even expect to be there. The former staging was ASRM, and that staging really showed extensive disease, but someone with 2 bilateral endometriomas was considered stage 4, but you could have an endometrioma with really not having any peritoneal disease or no obliterated cul-de-sac. So it didn't necessarily stage really how complicated the surgery was. So AAGL came up with this new schematic. It's a free app called AAGL Endo, which you can download to your phone, and you put in what your findings were on your laparoscopy, and then it will spit out what stage of endometriosis this is. And this really corresponds to how complicated the surgery is, how much dissecting you need to do. All right, so we have another Slido here. So what would be your initial management for endometriosis? It's multiple choice. So your options are NSAIDs and OCPs, surgical excision, GnRH antagonists or agonists, or high-dose progestins. Awesome. All right, 9 respondents. You guys all got it. So first, initial management for endometriosis is generally NSAIDs and OCPs. By the time they get to me, they've already had all of that. So we switch them up. I tend to then go to progestins. But when I talk to my patients about endometriosis management, I generally say we have 3 major goals. The first is to have as few severe pain days as possible and as few missed activities. The second is as few surgeries in their lifetime as possible, because every subsequent surgery is more dangerous than one before. And the last is to maintain their fertility if they desire it. So when you think about those management, the goal really is you want to suppress the lesion growth, you want to treat their pain, but you don't want to treat them with opioids because you give them another problem. And you want to treat the systemic effects of the disease. You really want to make sure that they can go on with their life. And like we talked about, early clinical diagnosis is important. You can treat empirically before surgical diagnosis. And response to therapy does not confirm diagnosis. Generally, I say you still want to find, if you're not working, you want to go to the OR and see what's going on. So here is a chart from a systematic review by Hugh Taylor, where he talks about the different treatment lines. So the first would be combined OCPs and NSAIDs, and then you can do progestins and NSAIDs. I would say then we switch to high-dose progestins after that. Second line therapy would be GnRH analogs, an aromatase inhibitor, an androgen analog. My general feeling about the second line therapy is that those are for a limited time. So I generally will go to this if I'm thinking about surgery and I can't get them their pain controlled with a progestin. I would then switch them to a GnRH analog. Or if they're close to menopause and want to try and avoid another surgery, we may use a GnRH analog at that time. The third line therapy would be surgical excision or ablation. I'm of more of the excision house when we think about what to do. I think many of the lesions that I'm resecting wouldn't be safe to ablate. So I find excision is actually safer, and I tend to do a cold cut excision for most of my lesions. And then fourth line would be hysterectomy with or without BSO. But the real important thing is to say, like, there's really no cure for endometriosis. So we're going to do the best we can, but explaining to the patient that it's a chronic disease. For patients who have a hysterectomy with ovarian conservation, they have a 60% chance of having recurrent symptoms, but it's usually not as bad, but 30% chance of requiring further surgery. So you really need to discuss whether or not to remove the ovaries as shared decision-making. I would say that most of my patients seem to do better without it, but there are a few patients that when we leave the ovaries, and we do need to continue suppressive therapy. And then patients who have had a hysterectomy with a BSO, they have a 10% chance of recurrent symptoms and a 4% chance of repeat surgery. So that tends to be more definitive management, but you need to consider what that means in the long run for having a surgical menopause. The excision may eliminate lesions, but there's up to a 50% recurrence rate in 5 years if the patient is not restarted on suppression post-op. And medical management does not improve fertility outcomes. So for a patient who presents with infertility, you really should take them to the OR. And even just washing out the inflammatory peritoneal fluid has been shown to improve fertility rates. And you can do a chromoperturbation and reopen some of those fallopian tubes. If there's, just some filmy adhesions within, you may actually be able to open those tubes up. So the surgical management goals are to reduce endometriosis-associated pain. We try to restore normal anatomy. It's ideal for infertility. Laparoscopy is the gold standard. And if you have deep infiltrating endometriosis, you really want to have a multidisciplinary surgical approach. Make sure that you have made friends with the colorectal surgeons, the minimally invasive general surgeons, and your urology folks, because that's really who are going to be your partners in full excision. Surgery is not curative, like we talked about. It's about a 50% recurrence rate, and repeat surgery rates at 2 years, about 15 to 20%. That's all patients that underwent surgery for endometriosis, and 5 to 50% at 5 to 7 years. And it's important to really restart medical management after surgery to reduce the recurrence. I would say the exception to that are for infertility patients. All right, we're going to move on to adenomyosis, which is the cousin of endometriosis. And these are patients who have an enlarged uterus secondary to endometrium growing deep within the myometrium. And the symptoms are similar to endometriosis, but they tend to have heavier periods, dysmenorrhea, chronic pelvic pain. Some are asymptomatic. Some have pain with sex, dyspareunia, and some have infertility. And I think when you think about management for these patients, you want to consider, are they primarily heavy bleeders? Are they primarily pelvic pain? Are they a combination of the two? Because that's really can help dictate your therapy. You can have focal disease, you can have adenomyoma, which can be difficult to tell the difference between a fibroid, or you can have diffuse disease. And the exact pathogenesis is unknown. It's similar to endometriosis in that there's these theories about it, and there's probably some combination of all of these that we see. But you can have direct invasion into the myometrium, so that may be from surgery, pregnancy, trauma. We see this a fair amount in patients post-cesarean section. We see it after myomectomy. You can have it after a DNC. There's thought that there can be altered immunologic activity. So if you have some infection in the uterus, that can lead to activated T and B cell production. It stimulates cytokines.
No, but I just went downstairs to open the door for you. You came in the front?
If you could mute your mic, thank you. And then estrogen plays a role in initiating and maintaining adenomyosis. There's also the Mullerian, some embryologic misplacement of Mullerian remnants. You can have invagination of the basalis and along the intramyometrial lymphatic system and bone marrow stem cells. Diagnosis is made from histology. The hysterectomy is standard diagnosis. You see an enlarged uterus with smooth surface, spongy, often with focal hemorrhage. So you can see here all these small little cystic lesions within the myometrium itself. We all know it. Those are the uteruses that are huge and they're heavy, and then you get your final pathology weight and they're much lighter because they've drained all the blood out of them and you don't get credit for the hard work. Imaging can help with a pre-op diagnosis. So ultrasound, you'd see a heterogeneous myometrial texture. We look for poorly defined foci of abnormal myometrial echotexture. You can have myometrial cysts, globular asymmetric uterus. I think this is a very, this is a nice way to see it in the office if you're doing a bedside ultrasound, and diffuse spread of small vessels within the myometrium. And on MRI, Really, we look for this thickening of the junctional zone greater than or equal to 12 millimeters, although I've had patients that had did not have thickening of the junctional zone, but we had a high enough suspicion and final pathology did confirm adenomyosis. Here's just some images on ultrasound. So you can see here these myometrial cysts and some increased vascularity of the myometrium. And here is on MRI. The arrow is pointing to focal thickening of the junctional zone, and that's a focal adenomyoma or focal adenomyosis. And then the other image shows a global adenomyosis of the whole uterus, and you can see the multicystic lesions within the myometrium itself. So for these patients, medical management tends to not work as well. I say for my patients who their primary symptom is bleeding, I can generally find ways, non-surgical or minimally invasive, to manage the bleeding. So medication tends to work, uterine artery embolization tends to work well for the bleeding, a Mirena IUD works really great for the bleeding. But for patients who their primary symptom is pain or pain and bleeding, that tends to be more challenging. So if a patient is done with childbearing, I generally do recommend hysterectomy as long as their surgical risks aren't too high. We usually try some medical management initially, but hysterectomy is the definitive management and cure, which is nice because unlike endometriosis, adenomyosis is cured by hysterectomy. On to interstitial cystitis or painful bladder syndrome. This is characterized by pelvic pain or pressure or discomfort related to the bladder, and it's associated with a persistent urge to void or urinary frequency. And it's generally a diagnosis of exclusion as well, so you want to make sure that there's nothing else going on. So the most important thing is to rule out infection. These patients tend to present with recurrent UTIs, they keep going to the ER to urgent care, but no one's ever come back with a positive culture. And so you tend to see that on history. They're up all night having to pee, they're in pain with a full bladder, they can have low volume, high frequency, low volume voids, and it's very uncomfortable. They feel better once they've relieved themselves. The etiology, the current theory is that you have defects in the glycosaminoglycan layer of the bladder wall, which is sort of the skin of the bladder, and you have this hyperpermeable epithelium, and any noxious urine solutes are absorbed and provoke inflammatory symptoms. There's some other theories about autoimmune or neurogenic inflammation. You can see these in patients can also develop these symptoms post-hysterectomy. You can get it in patients post-infectious. So we do have a fair number of patients who they may have started with recurrent UTI, and then that's led to interstitial cystitis. And here's just a schematic of the gag layer, which is this protective layer inside the bladder that gets thinned out. You can get pinpoint bleeding or glomerulations in the bladder. This is something we'll look for in cystoscopy, and I'll show you some images. Or a later stage of the disease, you get Hunter ulcers, which are ulceration in the bladder wall, which is a much more painful time. You want to consider interstitial cystitis in all patients with pelvic pain. Somewhere between 50 and 60% of patients with endometriosis have interstitial cystitis. You want to get a good history and physical. You get a clinical diagnosis. There should be some improvement with treatment. And cystoscopy is controversial. It's not the first line that you need to go for cystoscopy. Generally, if I'm taking a patient that has bladder symptoms and endometriosis symptoms to the OR for endometriosis, I will also do a cystoscopy at that time, generally with hydrodistension. And then I look for glomerulations and Hunter's lesions, which I can show you here. So on the left here are glomerulations in the bladder. They look like petechial hemorrhages that you'll see after hydrodistension. And then this is a Hunter's ulcer on the right in a patient before bladder distension. I've personally never seen Hunter's ulcers. That is something that I would refer to my urogyn colleagues or urology to treat the Hunter's ulcers. But glomerulations are generally a sign of interstitial cystitis, and it just helps to confirm diagnosis. First-line treatment for patient or behavioral modifications, just like we talked about, noxious urine can stimulate this. So the first thing I do is talk about Dietary changes, I recommend a low acid diet. If you don't have acid in the urine, it tends to be less painful. So having patients cut out spicy food, citrus fruits, red sauce, alcohol, sodas, that tends to help. I would say I have many patients that get 70 to 90% relief of their symptoms just from changing their diet. I also tend to recommend this medication called Preleaf. It's basically Tums for the bladder. So for many patients, you have to have that cup of coffee, and coffee can be a bladder irritant. So I recommend take 2 Preleaf before you drink your cup of coffee in the morning. If you're going out for drinks for your birthday, have 2 Preleaf before you have a glass of wine, and that should help. And Preleaf they can buy on Amazon. And then you want to think about other things like stress management and pelvic floor physical therapy. Like we talked about, many of these things are also associated with spasm of the muscles. You can have somewhat of a overactive bladder picture in these patients. So having pelvic floor physical therapy is important in that management as well. Second line therapy, there's some oral therapies. Elmeron has been recommended, but it's questionable nowadays. There's been some association with dementia, and people are being careful about prescribing Elmeron. You can use some of the antidepressants, so amitriptyline, hydroxyzine, and cimetidine also can be used. I find amitriptyline works really, really well. You do it at much lower doses. I generally start with 10 milligrams at bedtime. I would say 20 milligrams is sort of the magic amount I find, and patients do really, really well. And that secondary effect of fatigue helps them sleep through the night, which generally improves their mood overall. And then intravesical therapy. So we do this in my office, but we'll start bladder installations. There's different cocktails that people use. Nothing has been proven better. There's some data that you don't need to use steroid, but I use a cocktail of lidocaine to give numb. We use heparin, which is supposed to heal the gag layer. We put in lidocaine, sorry, we said lidocaine. We put in some steroid to reduce inflammation, and then bicarbonate to help with absorption of the medications. And the patients are told to hold their urine for an hour after installation, and we do it weekly for 6 weeks. And patients tend to do really well with this, and then they can follow up for monthly installations for maintenance therapy if they need it. Third line would be cystoscopy. For the Hunner's lesions, you can do Hunner's ulcers, you can do fulguration of the lesions, you can do some steroid injections. I don't do those things. This is stuff that I would generally refer to urology or urogynecology for. And then fourth line would be Botox and neurostimulation. And then fifth or sixth line is cyclosporin A or major surgery. These are some good resources for patients. ICHealth.org has a nice network for patients. Seeing a nutritionist to help with the IC diet, and then keeping a bladder diary. A lot of patients drink a lot more water than they need to, and their urinary frequency is actually related to the amount of intake. So really thinking about like, what are they taking in? I also have a fair number of patients that it's really associated with certain foods. And by keeping a diary, they were able to see that like watermelon, I had one that like watermelon really caused a big flare. And so she stays away from watermelon and her bladder symptoms are fine. Some people have also talked about nettle leaf tea as helping with some of the bladder symptoms. So there are some like herbal remedies that patients can use, especially if they're resistant to some of the medication. Irritable bowel syndrome. So this one is a major component of chronic pelvic pain. And this is a functional disorder. It is clinically diagnosed. So if I had a dime for every patient that came to me and said, I had a full GI workup, they did an upper endoscopy and a colonoscopy and told me I was fine, I would be rich. Like the answer is yes, your colonoscopy and your endoscopy are going to be fine in IBS. It is a functional disorder. It's multifactorial. There's no structural or anatomic explanation. The proposed mechanisms are this visceral hypersensitivity, which leads to disproportional pain with intestinal distension. So we don't know which came first, chicken or the egg, but we talked about this viscerosomatic sensitization, and we really need to understand that the bowel is sitting right there. And so if the bowel is upset, if you have any type of colitis, if you have any type of constipation or diarrheal illness, that will stimulate all of the structures in the pelvis. You get dysregulation of the gastrointestinal motility, and you can have endocrine effects by way of stress response on the hypothalamic pituitary axis. And that tends to be related to emotions. The most common diagnosis in chronic pelvic pain. So 50% of patients with chronic pelvic pain have irritable bowel syndrome, and you can have irritable bowel syndrome with diarrhea, constipation, or a mixed type. And the diagnosis is made by the Rome criteria, and I'm sure that many of you have patients that would easily meet this criteria. So it's recurrent abdominal pain or discomfort for at least 3 days per month for the last 3 months associated with 2 of the following: improvement with defecation, onset associated with change in frequency of stool, and onset associated with change in form of stool. And so asking your patients these questions will help you understand this, and finding a GI partner that treats functional GI disorders is going to be critical. You want to evaluate for red flags. You want to make sure you're checking for, like, are they having any bleeding? Do they see bright red blood? Do they have severe pain like rebound regarding, anorexia, weight loss? All important things to look for, because it may not be IBS. They may have something like IBD or cancer you really need to be looking for. And you want to treat the bloating and gas pain with diet modification. Antispasmodic agents are incredibly helpful for these patients. These patients tend to say, like, out of nowhere, they have a sharp stabbing pain. It lasts for like 10 to 15 minutes, or it can even last for up to an hour. They're keeled over in bed. Generally, I will give them a prescription for Levsin, which is hyoscyamine. They put it, and it's a dissolvable tablet, and they put it in their cheek, and it dissolves and it relaxes the intestine. It's a PRN medication. So I say, just keep these in your bag. If you have that severe sharp pain, stick the tablet in your cheek, let it dissolve, and see if that improves your symptoms. For patients who have chronic constipation, you want to treat that. You can do fiber laxatives. Miralax tends to work really nicely. The laxatives can aggravate some of the gas and pain symptoms with the stimulation of the bowel. So you just want to keep that in mind. And then for diarrhea, you can use Imodium, loperamide for those patients. SSRIs can help with quality of life, but it can alter some of the bowel symptoms a little bit. You want to think about how you're using them and decrease the pain. And then, of course, referral to GI. It's really important to find a GI partner for this. Nearing the end, myofascial pain. This is an important part of any pelvic pain physical that you do. So musculoskeletal pain, myofascial pain is for musculoskeletal pain that originates from a trigger point in the muscle or fascia. And you can have discrete hyperirritable points of tenderness in a taut band of skeletal muscle. And we think it's due to dysfunctional electrical activity at the motor end plate, and or aberrant nociception. And that's what we talked about. So it can be that you had this, you have chronic pain in your pelvis, like just like if I punched you in the stomach, you're going to tense those abdominal walls, you're going to tense the pelvic floor. When you have chronic pelvic pain or GYN pain or IBS, you're tensing those muscles all the time and guarding, which is helping you with your initial pain. But now you get a new pain, you get this muscle spasm. It's found in about up to 75% of chronic pelvic pain patients. The Carnet test is the physical exam that we do to assess for abdominal wall trigger points. It's performed when the patient is supine on the table with a relaxed abdomen. You push on their abdomen with one finger, and if they feel pain, you have them do a crunch or tighten the abdominal wall. And if their pain gets worse, that's a positive trigger point sign. I usually mark it with an X with a ballpoint pen. If their pain gets better, then that's visceral pain, and you move on. And so I always start my physical exam by doing an abdominal exam where I push along the rectus abdominis muscles in the pelvis, and I do upper abdomen as well. And then if they do have trigger points, we can do trigger point injections where I inject lidocaine into like the myofascial junction of the patient. They can also get lidocaine patches can help with this, and you can use TCAs, anticonvulsants like gabapentin, muscle relaxants can help with some of this. And then you want to look at the pelvic floor, because the vaginal wall is made up of a lot of muscles, and that's what you need to look for as well. So when I do my vaginal exam, I don't go straight for the cervix and the uterus because that is going to stimulate pain receptors everywhere and you're going to have trouble localizing the pain. So I always start with a digital exam with just one finger and I palpate. I'm right-handed, so I use my right hand and I go counterclockwise, but I start at 10 o'clock to palpate the obturator muscle. Then I go from 9 o'clock all the way to 3 o'clock to palpate the levator ani muscles along the way and feel if they have trigger points along the way. And you can feel hypertonicity, like you get kind of a spasm of the muscle and they'll jump with severe pain when you push on that muscle. And then I sort of turn my hand around and palpate up at 2 o'clock for the other obturator muscle. And you can do directed pelvic floor injections for the levator ani spasm, which is tends to give immediate relief to these patients. So symptoms that patients may have with this are pain when they're sitting in a flat chair. They may have worsening pain or pressure over the course of the day. They can have mid-vaginal dyspareunia, and the pain or soreness can persist to 1 to 2 days after exam. So generally these patients after having sex may have a lot of pain. You need to think about this in any patients that have dyspareunia. They may have feel like a knife is stabbing them in the vagina or in the rectum. After having a bowel movement, the levator ani muscles can spasm after bowel movement. I see this frequently, patients saying that when they have their period and they have some constipation, they are crying and have excruciating pain with defecation, and that tends to be pelvic floor tension myalgia. This you really want to treat with physical therapy. Pelvic floor physical therapy is a wonder. It's amazing. I recommend it to everybody. You can do levator injections. We do directed injections into the levator muscle. You can use a pudendal set. We tend to use spinal needles we use the sheath. We cut it about 1 centimeter back and then put the sheath in. Palpate the area, put the sheath in, and then put the needle through the sheath to protect our finger. We inject directly into the levator muscles. You can do a pudendal block. These I leave to my anesthesia pain team to do pudendal blocks under ultrasound guidance. But if you're comfortable doing them, you can do them in the office as well. You can use muscle relaxants, vaginal Valium, and Botox injection. And then our last topic, but not last but not least, is psychiatric component. And again, this can be an initial cause or it can be a sequelae, but the criteria for major depression is met in approximately 12 to 33% of chronic pain patients, and I believe that that is an underrepresentation. You really want to look for psychiatric illness. So you want to get a complete history and physical, consider sexual abuse. There's behavioral sequelae like emotional reactions, PTSD, or distorted self-perception in patients with sexual abuse. And then there can be physical effects like chronic or diffuse abdominal or pelvic pain. They tend to have a lower pain threshold and anxiety and depression associated with it. Chronic pelvic pain can be a somatization of anxiety or depression, so you want to make sure you have a multidisciplinary approach. Validation of their pain is very helpful, and you want to treat their anxiety and depression. It's very important that you're partnering with a psychiatrist and a therapist. And chronic pelvic pain can lead to psychiatric illness, such as drug addiction, and especially if you're treating chronic pain with opioids, and depression, anxiety, and insomnia can also be associated with chronic pelvic pain. So it's important to consider the sequelae of those as well. All right, that was a lot, but in summary, chronic pelvic pain is pain in the pelvis for greater than or equal to 6 months. That's really debilitating for the patient. It has a lot of possible etiologies. It's not just GYN, so you really want to think about all the causes of pelvic pain. You need to consider central sensitization and the need for multimodal therapy. Make sure to screen for sexual abuse, psychiatric illness, and drug abuse, and do not treat chronic pain with opioids. Yeah. I said that you have this huge canyon, but when you get to the top and you can see the perspective, this is actually Zion National Park. The view is beautiful and you can really bring life back to these patients. Does anyone have any questions?
Thank you, Dr. Keltz. Thank you so much, especially that last cartoon. That's definitely my favorite. Excellent. All right, well, are there any questions? I see that Dr. Saluki has a question.
Hi, Dr. Keltz. Thank you so much for your presentation. I'm Shirley Saluki. I'm actually one of the urogynecologists here. And of course, as urogynecologists, we see a fair number of patients that, in addition to their other complaints, may have pelvic pain. So my question to you is, how do you manage to squeeze all of that management into those short visits? Like what's your strategy for really properly evaluating these patients given our limited time?
I will say I'm very fortunate in that my practice, they allow me to spend an hour with a new patient. So I see in 1 hour, I have 3 patients. I see one new patient for an hour, and then I have 2 follow-ups. And so I really do get the time. I spend about an hour with with my new patients for pelvic pain, especially. And then I have them follow up every 3 months. And so we just have very close follow-up and monitoring of how they're doing. And so I find that just understanding who they are and keeping that close contact keeps me up to date with what's going on. We have PAs in our office that will do our trigger point injections and our bladder installations and levator injections. So a lot of those repeat follow-up things that we're doing kind of on a weekly or a bi-weekly basis are the time is filled by my PA, which is incredibly helpful. Before we had a PA, that was really filling up my entire panel. But it's mostly the nature of my job that I have the luxury of spending a full hour with these patients.
I see that Dr. Phillips has her hand up.
Hi, thanks for that great presentation. I love the fact that you kept saying partner with, because, you know, it does take a village with these patients. My question is, I don't even know how to phrase the question. I find that other than kind of my Urogyn colleagues, that my GI colleagues tend to not be very helpful, and that the patients themselves, no matter what their symptom, come to their gynecologist. Do you try to educate your patients, you know, this symptom belongs to this person, or if you're having this problem, this is the team member you need to see, or do you kind of take it all upon yourself? Because I find that we wind up taking it all upon ourselves. I don't know why, as gynecologists, I don't know if we're more sympathetic to these patients or if we're more accessible, or I don't understand that phenomenon. And I want to know if you see that same phenomenon. And I like the fact that you gave us different hints on how we can easily manage some of these disorders. I shouldn't say easily, because none of this is easy, but how do you deal with that?
Yeah, I agree with you. That is a major challenge. So I tend to be the general contractor for their care. I would say that I don't know what it is about being a gynecologist, but I do take responsibility for multiple organ systems when it comes to chronic pelvic pain. The tips that I shared with you today of how to start the management is because I did struggle, especially in the beginning of my practice. I was the first, I started the practice here. So I came in and didn't know anybody. I had come right out of fellowship when I started here. And I had to figure out how to do everything I needed to do without the resources. And so many of these tricks, these initial therapies, actually got my patients the majority of the help that they needed. And then through the last few years, I've worked on building relationships with other colleagues that can help. So I do find GI is probably one of the more challenging practices to work with. I think they're very overwhelmed, and it can be hard to get a patient in that has pelvic pain because it's not life-threatening and they're moving the more urgent cases to the top. So I do find colorectal sometimes is more helpful in that area because it might be a surgical candidate for them. So they may be willing to do the colonoscopy or manage some of the chronic constipation. And so I think a lot of it is trying to be nice and make friends with the people that you could potentially recruit to your team. And it may be slow, and it can be painful, for lack of a better word, but it ultimately, the hope is that you'll, even if you find one person to be your partner, you can really help a fair number of patients. Many come with a GI, so, or a psychiatrist. So that's helpful too, is that if you're willing to pick up the phone, I find the personal human connection makes a tremendous difference if you just pick up the phone and talk to another physician about the patient.
And I guess as a follow-up to that, I also have a tremendous problem with access, especially, you know, with different insurances, underinsured, to the pelvic floor physical therapist, to the, you know, cognitive behavioral therapists. So, you know, like you said, we tend to take a lot of that on, you know, by ourselves. And I think the concept of a whole team is so important.
We have, my practice is 70% managed Medicaid. So, and I do see charity care as well. So I do agree. I find my patients who have the worst disease and can't hold a job and can't maintain their life, don't have insurance and can't afford to feed their families or have a roof over their head, pay, you know, $200 a session for a therapist. So I do think resources are limited, especially for those who probably would benefit the most from many of these resources. I have a dream, and we are working on doing centering here in my practice and hiring a social worker. I find a lot of these patients feel that they're on their own and they don't recognize that there are a lot of people that out there that are suffering similarly. And I think having shared experiences with others would be helpful. So I'm hoping to do some sort of group centering in the office with a social worker running it, and hoping to provide some of those services and have it be covered by their insurance. For pelvic floor physical therapy, we've created a packet with a list of different pelvic floor PT centers throughout the tri-state area. And it's all just built on reputation. So if a patient goes somewhere and they have a great experience, they tell us and we write it on our form. And then I have a general idea of which ones take insurance, and I will be like, here are the ones in your area. I starred the ones that take insurance, call around, see who you can see. But pelvic floor physical therapy is amazing. I think every woman postpartum should have physical therapy regardless. So finding a good partner in physical therapy is really important.
All right. Well, Dr. Keltz, thank you so much for this excellent talk. This is very much what we need to hear. So thank you so much.
Thanks for having me.
All right. So we're going to end it now, and I wish everyone a safe and productive day.